All right, so UTIs. Now, this is an umbrella blanket term for any infection in anywhere in the urinary tract. Okay, so what is considered in the urinary tract? Name the places of the urinary tract. Kidneys, which go to the ureters, which go to the bladder, which goes to the urethra. So if there's an infection anywhere in there, we call it a UTI. Now, people now call a UTI, like if they say like, oh, I have a UTI, they usually mean a bladder infection, right? But a UTI can be anywhere. That's why at the top of this, right, it'll say UTIs, then we have different types. Today, we're going over cystitis and pyelo. Cyst means not like a cyst on your skin, but like CYST.
Oh, that means bladder.
That means bladder. Okay, cyst means bladder. Cholecyst means gall bladder. Okay, but cystitis would mean a bladder infection. Pyelonephritis, pyelo means fire actually, but okay. But yeah, kind of like pyro. No, just kidding. But pyelo can also mean kidney. Kidney-itis.
Infection.
So there's an infection and inflammation of the kidney. So this would be a UTI in the cystitis would be a UTI of the bladder. Pyelo would be a UTI of the kidney. So if a bladder infection goes untreated, can it not travel up the ureters and go into the kidney and cause a pyelo?
Yes.
Okay. And then isn't all your blood going through the kidneys and just picking up that pyelo, that infection, and then taking it to the rest of your body? So pyelonephritis is very often that it goes into sepsis. Do we understand?
Yes.
Okay. So we're going to start with cystitis, which that's the typical thing that people say when they're like, I have a UTI, and they usually mean bladder infection. Okay. So why do females get cystitis more than males?
Poop hole.
Excuse me, what about your poop hole? She said our poop hole. What about it?
Too close.
They're too close. The two holes are too close. Okay, so they're very close. There's a moat. Right? I'll never forget that as long as I live. And then we also have a shorter urethra, right? Male's urethra is going to be longer. Ours is shorter. Okay. What is the most common organism for a UTI? E. coli. Okay, because it's, you know, the poop hole, she says. Okay. All right. So infection of the bladder caused by poor hygiene. Could be poor hygiene. You just didn't clean your TT. You have got to clean yourselves. Okay. Now your urinary tract is self-cleaning. So you don't need to stick anything in it. Okay. It will clean itself, but you do need to clean the outside. All right then. Wiping from back to front.
No.
That's a no. That's going straight from the poo hole through the moat to the front hole. I cannot record this. Sorry, people that are watching this. All right. If they hold their urine, now nurses are notorious for getting bladder infections because you have to go 14 hours sometimes without peeing. Any pee that just sits in the bladder gets infected. Okay. VUR. What do we say VUR was? Vesico. Not testicular. Okay. Vesico. Ureteral reflux. Y'all say it with me. Vesico ureteral reflux. What is VUR? It's GERD of the ureters. That was just so easy now, right? Okay. So that's a structural problem, right? An anatomical problem. So the urine will come down and then back up and down and reflux back up, right? And so it's just sitting in there. So it's getting infected. Yeah. Okay. Any kind of irritants like bubble baths, like putting any like bath bombs, any of those chemical things that go like on the outside of your privates is going to irritate it and you can get an infection. Okay. Lack of hydration. So if you're not drinking enough water, your urine's going to be very concentrated and gross. It's just very gross. Why would constipation cause a bladder infection? Oh, that's a possibility. You could also be dehydrated or not drinking enough water, but your bladder's right here. Your gut is right here. So if it's full of poop, it's going to push on it and then you can't completely empty the bladder. So some of the pee will stay in there. Why are you laughing? Oh, your face just looks like that. Okay. All right. Synthetic materials like yoga pants, wet bathing suits, right? So like anything that isn't cotton that's supposed to be absorbent is like a haven for UTIs, even though I live in these pants. Not voiding after sex. This is a big one because there's a lot of bacteria that gets traded during sexual intercourse. So you're supposed to get up and go pee afterwards to flush it all out. Do we understand?
Yes.
Good girls. What is a CAUTI? Catheter associated UTI. Whose fault is that? That is the nurse's fault because you did not use sterile techniques. Do we understand?
Yes.
Okay. So in order to prevent a CAUTI, then this is sort of tricky. What's a number one way to prevent a CAUTI? No, surprisingly. No, it's an indwelling catheter.
Take it out as soon as possible.
Yes, that's it. Take it out as soon as possible. Every day you're going to assess the need. Do they even need a Foley? Right? Because patients don't need a Foley unless they absolutely cannot void on their own. I don't care if they're incontinent. I don't care if that's all fine. They can go in a chuck or a diaper or whatever, but absolutely. There is no reason to have a Foley cath unless you absolutely cannot void on your own without a tube in your bladder. Okay. Oh, you did? Yeah. Foleys are like a no-go. You have to absolutely prove it's not for convenience. And a lot of people try to put them in for convenience. Oh, they're incontinent or, oh, they can't get, I don't give a shit. Okay. That Foley is going to cause massive infection because if they get a bladder infection, then it can go to the kidneys and then it can go to sepsis, especially in elderly clients. Okay.
I was taking care of a Parkinson's patient. They sent her home and she had a catheter.
Why did they send her home with a catheter?
I don't
See,
know,
that doesn't
but
need to happen.
She was leaking around.
I'm
it,
sure she was
and
leaking around it.
She
Yeah.
was a respiratory therapist, so she like knew what was going on, but she couldn't do anything. It was the urine.
Yeah, I bet it did. Yeah, this is very dangerous practice. So the first thing is to like make sure that you take it out, you know, like if you possibly can take it out, take it out. And then obviously good hand washing, sterile technique, and you're supposed to do perineal care every shift. I've never seen nurses do that. But how gross is that to have a tube sitting up in there and then they don't even clean their privates? That's repulsive. She did clean. That's good. She probably had a student. So yeah.
She wasn't a nurse. She was
Oh.
a PT.
Wow. Then that's really nice. That's really
She
nice.
was a PT, and the patient, she had like something, a brain. So they found her unconscious in her house, and so she had to have surgery on her brain.
Oh.
And, yeah.
Dang, that's serious. All right, signs and symptoms. We will have dysuria, which means
Painful.
burns when to pee. Low-grade fever. It's not a huge infection. This you can treat outpatient, right? We hardly ever put a cystitis in the hospital. Suprapubic pain. Where's the pubic area? By your TT. Where's the supra? Right above it. That's where the bladder is located, right above your pelvic bone. Yes? Okay. They may have low back pain too, because it's like, you know, inside. So yeah, that may go to the back. Urinary frequency, meaning they're having to pee and pee and pee, but then when they go and they sit down, have you ever had one?
Yes.
A UTI, it's horrible. Like you sit down, then you can't, like the little bit that does come out burns like razor blades. Their urine specific gravity will be, it'll be increased because you've got bacteria and nitrites and all of that junk in it. Yeah. It may smell bad. Yeah. And you may just feel kind of crappy, like just kind of junky, you know. You may have a little bit of hematuria, but not much. Your bladder is very vascular, so it does get kind of irritated, may bleed a little bit, but this will not be a massive amount of blood. Got it? All right. How do we diagnose any bacteria? A culture. Now we'll do a UA, which y'all know how to do that now, but we have to do a culture, right? The UA will kind of give me an idea of like, ew, this is gross, but y'all have seen a lot of disgusting urines that did not grow anything, which basically means it was just really poor hygiene. Because as the urine like hits the outside of their privates, like it picks up all of the, you know, yeah. So in the UA, the specific gravity will probably be high. What might I see in the urine that may tell me like this person probably has an infection? Leukocytes, nitrites, bacteria, not protein, because it's not a kidney problem, right? White blood cells? Oh, that's leukocytes. Yeah. Sorry, I'm stupid. All right, but then we have to send it for a culture. But I need to treat them in the meantime because I can't wait 3 days for their culture to come back or it'll go all the way to their kidneys already, right? What's that called when I treat them with antibiotics before the culture comes back? Sarcini. Well, that was then, this is now. It's called empiric antibiotic therapy. Empiric, which means I'm going to do my best guess what I think this patient needs. And then when I get the culture back, it'll show me what they're susceptible and resistant to, and I may need to switch the antibiotic. Does that make sense? Okay. All right. When the culture comes back, that is diagnostic. Got it? Treatment, they can usually just get PO antibiotics at home, 3 to 10 days, depending on how severe the UTI is. Okay. We can tell them to take like some Tylenol or ibuprofen or something for the pain, right? There is a urinary analgesic that they really like to test on some kind of way, some kind of where, and I'm going to write it up here because I didn't write it on your chart. This you can get over the counter. Okay. It is called phenazopyridine or something like that. Okay. Azo. Yeah. So it is a urinary analgesic. What is an analgesic? Huh? Yeah. So it just basically makes it not burn when you pee, which is one of the worst parts of the UTI. But it turns your urine orange. So they have to come and do the UA before they start taking the AZO, because it will dye the urine strip and then you can't tell what's what. Okay. All right. So nursing care, lots of teaching. So all of the things that we did before, the causes, that's what you're going to teach them. So what kind of panties should they be wearing? White cotton underwear. Okay. No bubble baths, no synthetic materials, right? I know white cotton panties. White from front to back, void after intercourse, treat your constipation. Y'all see what I mean?
Yeah.
Okay. Increase their fluids, cut down on juices, sodas, things that are real sugary, because what like sugar? Bacteria. Yeah. Tell them to void frequently. Make sure they're going to the bathroom often. Do we understand how to treat this?
Yes.
Okay. Do we understand cystitis?
Yes.
Let's go to pyelo. This is the big daddy. Oh no, that was cystitis. Boo boo. Oh, whoopsies. Switch it. All right. Pyelonephritis. What is it? Infection and inflammation of the kidney. So now the cystitis either went untreated or partially treated, went up the ureters and into the right. And what's our big risk with pyelo? Sepsis. Okay. So this is a way worse infection. When your kidneys are infected, I mean, that's pretty bad.
Yeah.
Okay. But I want to be very clear. You are not in kidney failure. You are not in AKI. Now, it is a possibility that it could lead that way if it went untreated. Yes. But this is not like a hypertension, increased BU increase. This is not like that. This is an infection of the kidney. And we just take it at face value. Okay. Cool. All right. So infection of the kidney was either an untreated cystitis or something else happened. Like, let's say you had kidney stones, which, by the way, what are kidney stones called? Either renal calculi. They're also called. What's the actual like word for stones other than calculi? There are some calcium stones, yes, but I'm looking for the word. Just in case y'all see it on an exam, you're like, why didn't I know what that was? The word for stones is lithiasis. Anytime you see that, that's a stone. Okay. What type of stones are we talking about? Kidney. What's the word for kidney? Nephro. So nephrolithiasis means kidney stones. Also renal, which means calculi, which means
Calcium.
stone. Okay. Both of these are saying kidney stones. Okay. So if you have a kidney stone that's in the ureter, then can you pee very well from the kidneys? No, that urine's just going to sit there. It's going to get gross. It's going to get infected. Okay. VUR. God, there's a lot of VUR in this lecture. What was VUR? But what is it? Vesico ureteral reflux, the GERD of the ureters. So that's the urine's going down and then back up and then down and then back up, right? So you're just giving this like junky urine to the kidneys. Okay. If the patient is immunocompromised, obviously they're going to be much more at risk. If they have prostatitis or BPH, how come? Because it wraps around the bladder neck, right? So it's not going to, you're suffocating the bladder. So it doesn't let the urine release, right? Why would pregnancy, why would they be more at risk of pyelo? The baby's pushing on it. They have double the blood volume. So your kidneys have double the work to do. Baby gets pushing on certain things and you can't release urine. Frequent caths. That's why you're not supposed to cath your patient unless they have the inability to void. Do we understand?
Yes.
Okay. All right. So the signs and symptoms are going to be much more severe than cystitis because this is a bad infection. So they're going to have a high fever. They're going to have flank pain, which is where? High up in the back. So that's where the kidneys are. Nausea, vomiting. What is leukocytosis?
White blood cells.
White blood cells are what?
A
A lot.
A lot.
Yeah, so now you can actually see white blood cell changes in the CBC. They're gonna have pyuria. What's pyuria? Pus in the urine. Pus in the urine. Malaise, fatigue, anorexia, hematuria. What's hematuria? Blood. Now, yes, I would expect a good amount of blood because the kidneys are very vascular. Yeah. CVA tenderness. What is CVA tenderness?
The central
Costo.
costo.
Costo
I don't remember.
vertebral angle tenderness. What does costo mean?
Ribs.
Or chest. Yeah. And then the vertebrae. It's fine. So where your spinal cord meets your last rib, that makes a 90-degree angle. That is called the costovertebral angle. Your kidneys sit right up in there. So you're going to go in and you're going to take your fist and just give them a love tap right at the CVA. Okay. And if they're like, oh my God, that hurts. I'm like, you have CVA tenderness. Thank you. Okay. And that is a sign of pyelo. It's also a sign of kidney stones because you could have stones in there too. Oh, what I will tell you, because I didn't write one of these on stones because I'm just not sure where they stand on this. You'll have to let me know. But kidney stones and pyelo have the exact same signs and symptoms. Exactly. And isn't it possible that kidney stones could cause a pyelo?
Yeah.
So I really have to go and look and see, is this kidney stones? Is this pyelo, or is it both? Because the signs and symptoms are just the same. The only thing that's different with kidney stones is that their pain can radiate down to the groin, because you've got your kidneys here, you've got the ureters, right? And then you have the bladder. So the bladder is like almost in your pubic area. That's why the pain may radiate towards the groin in kidney stones, but not in pyelo. Okay. But the signs and symptoms, they're going to look the same. They come in with high fever and they're puking and they're in severe pain and like they are miserable. So then I need to find out, is this an infection? So how do I find out if it's an infection?
White blood cells.
Okay, so we could do a CBC for white blood cells. I need to do a UA and a urine culture. Okay, but the UA and urine culture just tell me if I have a UTI. It doesn't tell me where it's located, correct?
Yeah.
Okay, the white blood cell count will kind of give me a better idea of like, okay, this is probably a pyelo. But now I need to actually look at the kidneys.
Oh,
Right?
what a BGF.
No, not like the function of the kidneys.
Oh,
Remember,
okay.
the function is fine, but I need to actually look, is this kidney very angry? So I just do a renal ultrasound. It's non-invasive, right? I can just look at the outside, but if I think they have kidney stones, I need to do a CT because I can only see the stones with a CT. An ultrasound is very rudimentary. All I can see is like outlines of things, right? But a CT would glow and show me like where the kidney stones are located, right? Do y'all understand what I'm saying?
Yes.
Okay. So the ESR and CRP may be elevated in pyelo, because what is ESR and CRP? They're markers of inflammation. And this is a very big, giant, angry inflammation. Yes? Okay. BUN and creatinine may be slightly elevated, but not like what you would see in an AKI. This is not an AKI. So we can still run it, but if it doesn't show anything, that doesn't mean it's not pyelo. Okay. Now I also need to draw a blood culture. Why am I drawing a blood culture? To make sure they're not already septic, right? And a blood culture can take up to 5 days to come back. So I kind of need to get on that. Yeah. All right. So a lot of times they will be admitted with pyelo because this is a pretty bad, ugly infection, right? So we're going to give IV antibiotics, right? Analgesics, probably opioids because it's very painful, antiemetics. Okay. And we're going to do the same thing for kidney stones, except for they don't need antibiotics unless they have a coexisting infection, right? With kidney stones, since something is stuck, your number one thing is to give them lots and lots of fluid so we can flush that kidney stone out, right? Okay. So nursing care for pyelo. So we need to do a daily weight. We're going to watch their urine output, of course, their eyes and nose, yada, yada. We can watch their BUN and creatinine because I am worried about an intrarenal AKI. That can happen, right? So I am going to watch that. Okay. I do need to watch their blood pressure, and I do not expect it to be very elevated because their kidneys are still functioning fine. But if we're getting to the AKI point, then I would see a change. So that's why I'm monitoring it. Does that make sense?
Yes.
Monitor for signs of sepsis because that can happen real quick. What are the first couple signs you might see of sepsis? Huh? Sepsis doesn't hurt. They probably won't. That's that would be the first sign of an AKI, maybe.
Fever?
High fever that is unresponsive, sure. But one of the biggest things of sepsis is persistent tachycardia. No matter what you do, their heart rate is very, very high. The fever is difficult to treat. Okay. And what would their blood pressure do? Why?
Something's
Because your whole body is going to say,
Something's
and you're
wrong.
going to leak into the. Mhm. And then what's a lab test that we can do that is faster than a blood culture that tells us they're getting septic? Yes. Is that?
I know it's
It starts with an L. Mhm.
Lactate?
Lactic
No,
acid. Yeah. And if lactic acid is greater than
4?
4, that means your patient's septic.
Mhm.
Okay. If it's greater than 2,
Okay.
then we're going to be like, ooh, they might be getting septic. I'm going to repeat the lactic acid again in an hour and see if that has changed or if it's trending up. Does that make sense?
Mhm.
Because I only got 5 days to wait. Right?
Right.
Okay. All right. After resolution of pyelo, so after it's done, like even one episode of pyelo can cause permanent kidney damage. So I'm going to do something called an IVP. That is an intravenous pyelogram. So IV intravenous, obviously we're going to put in contrast. Pyelo, which means kidney, a gram.
Picture?
Yeah. So you put in contrast. You don't have to write all this down. You just need to kind of have an idea of what it is. So they put in contrast in the IV. Okay. And then they take what's called a KUB. That just means an abdominal ultrasound. It stands for kidneys, ureter, bladder. That's what I'm looking at. They take the picture and then they're like, hey, go to lunch or whatever and come back in about an hour. They come back in an hour. They take another KUB. They're watching that contrast go through to see if it stops on one part. Like, is there an obstruction? Is there a VUR? Is there a stone? And they do that several times until the contrast goes all the way out of the body. Does that make sense? Okay. And then we can also do a KUB, which I said is basically an abdominal x-ray. Okay. All right. Do we understand cystitis versus pyelo?
Yes.
Now, the only thing I will mention for kidney stones, okay, the biggest things are fluids and strain the urine. They have to strain the urine because I need to know when it came out. Okay. So they'll put a strainer, like a little strainer thing in the toilet. So that way, every time they pee, once it catches the stone, once the stone comes out, then they will put it in a cup and send it to the lab so they can find out what type of stone it is. And then I will treat it from that way. There's 5 different types of stones. I don't think you need to know the 5 different types, but you do need to know that there are different types, which is why we strain the urine. But the treatment is going to be very similar to pyelo. We're doing massive IV fluids, right? We are doing antiemetics. We're doing antipyretics, all of the same stuff. So if you understand pyelo, you can understand kidney stones. Understandable?
Yes.
And we finish early. Do-da, do-da.